Welcome to today's webinar. My name is Jose Francisco, Project Manager at the IAS-USA. Today's webinar will be going over COVID-19 vaccine hesitancy, crucial conversations, and effective messaging for patients and healthcare teams. I'd like to welcome today's moderator, Dr. Constance A. Benson from the University of California, San Diego. Welcome, Dr. Benson.
Thank you, Jose, and welcome to all of our registrants for today's very important webinar, very topical webinar, given what's happening in our country and around the world today. So it's my pleasure to be joined today by Dr. Marie Brown, who is the Director of Practice Redesign in the American Medical Association and Professor of Internal Medicine at Rush University. I'll formally introduce Dr. Brown in just a moment, but we're going to go through a few housekeeping slides for the introduction here. This is a CME accredited program, and the IAS-USA designates this live activity for a maximum of 1.25 AMA Category 1 credits. Next slide. We also are offering CME credits for nursing contact hours, pharmacotherapy credit, pharmacy contact hours, and ABIM mock points. And this slide gives you the instructions for how to file for CME accreditation for attending this program. Next slide, please. Our webinar today is supported by unrestricted grants from a number of supporters. Our platinum supporters are Gilead Sciences, Merck, and ViiV Healthcare, our silver supporter, Janssen Therapeutics, and bronze supporter, Theratechnologies. So we thank them for the support of all of our ACCME programming. Next slide. So just a few words about navigating the webinar. We will be using poll questions, and when we do so, a separate window will show the poll questions. You'll be able to choose your response for the poll, and those responses will then be displayed after the poll closes. If you have questions on the program today, please be sure to submit those questions using the Q&A button. We have a tremendous number of really highly insightful questions that were submitted by our registrants in advance of today's program, and we've made note of all of those, and we'll be addressing them either during the talk itself or at the end during our Q&A session. We will apologize in advance if we're not able to address all questions, but we will do our best to do so. We have left the chat open as well, but we would like you to use the Q&A button on your webinar and your Zoom call to address our questions. That will help us keep everything organized and be able to follow and understand which of the questions we've answered or not answered as of yet. So please do use the Q&A. If there are comments you want to make to your colleagues or to us, feel free to use the chat as well. Next slide, please. So our first poll question today is, have you received a COVID-19 vaccination? Please understand this is a totally anonymous poll, so nobody knows who's answering. Please feel free to address or answer the questions and yes, no, or prefer not to answer. Okay, that's really great to see. 98% of our audience is already vaccinated. So congratulations and thank you everyone for that. Next slide. If we can move on to the next slide, please.
I see it.
Oh, we seem to be stuck on poll question number 1 on my screen. Okay, poll 2. Do you have a family member or acquaintance who declines COVID-19 vaccination? Please choose one of these choices. Yes, one, yes, several, no, or prefer not to answer. Okay,
Wow.
So it looks like we have quite a few of our audience who are dealing with vaccine hesitancy themselves, and hopefully this will be very appropriate for your discussions. So can we move on to the next one? So we're going to dive right in now and introduce our speaker for today. Dr. Marie Brown is an internal medicine specialist with over 30 years of experience practicing as an internist in several settings, including federally qualified health center, small private practice, and a large integrated medical center. She is the director of practice redesign for the American Medical Association, a professor emeritus for the Department of Internal Medicine at Rush Medical College in Chicago, a past governor of the American College of Physicians, and an ABIM board member. She's a frequent guest lecturer at academic, national, and international healthcare conferences, and her specific areas of expertise and publications include practice efficiency, the joy of practicing medicine, medication adherence, and most specifically for today's talk, adult immunizations. Dr. Brown received her Bachelor of Science degree from the University of Dayton and her medical degree from Rush Medical College. She did her residency in internal medicine in Rush Medical College in Chicago as well. So I'm going to turn the program over to Dr. Brown, who's going to give us her insights into how to talk to our patients about vaccines. Thank you, Dr. Brown.
Thank you, Dr. Benson. And do I have control of my slides? I hope so. Okay, great. I'm going to talk for about 25 minutes or so, and then we're going to have plenty of time to talk with Dr. Benson to get your questions answered. As she said, we have lots of wonderful questions that have already come in during registration. I am truly honored to be with you today and share some of my experience and what I've learned honestly from my patients about how to communicate more effectively, because in my, and probably many of you on the call, entire career, never have we had a more challenging time from a public health concern than today, right now. And as it is, we face this with, everybody on the call. So 73% of you listening in have at least one acquaintance or several who are hesitant and haven't received their vaccine. So hopefully we'll be able to provide lots of solutions. Let's look at the learning objectives. We're going to talk about patient experiences, the effect of social media and how we can use it to our advantage, and use really how we can change, because we have more control over our emotions and our attitudes than we have over anybody else's. So using humble inquiry to understand and move our wait and see patients toward vaccine accepting patients. Here's our first pretest question. Who do patients trust most regarding vaccinations? My screen doesn't match up this, so look at the pretest one. They're physician and healthcare practitioners. Do you think they're local public health department or pharmaceutical companies? Choose one of those three, please. And you'll see these at the end. And who do patient? No, I've got a different one there. Here we go. Pretest question number 2. Most of the wait and see group of patients have already received their vaccine. True or false? Hit number 1 for true or false. And again, you'll see this at the end of our 25 minutes together, and then we'll have plenty of time for Q&A. Okay, thank you. So these are really crucial conversations. To level set, I'm going to talk very briefly about the anti-vaccine movement and the history, some conspiracies that we need to know about, the effect of social media, and then really focus on solutions. I'm trying to change there we go. And it's very helpful, I think, to highlight that immunizations are right up there with safe drinking water as the most important health interventions in history. But if we don't remember the days of vaccine preventable diseases, which many of our patients don't, we're condemned to repeat it. And that's where we are now. This mistrust alone will really endanger our getting past or any kind of control over this pandemic. And the one thing I really would hope that you remember, the one slide is this. Most of you have been vaccinated. Most of you, I believe, are in healthcare, and you are the most trusted source. Now, whether you're a psychiatrist, an infectious disease expert, a primary care doctor, physical therapist, we all need to be giving the same message because we are the most trusted source of information. And if we don't, we'll live as we are now with measles and polio. This demonstrates the cases around the world. Measles was eliminated in the United States decades ago. This is in 2008. And only a few years later, because of vaccine hesitancy, these are outbreaks in the United States. We are experiencing the same thing with polio. And we know that religious leaders in Pakistan told mothers that the polio vaccine was laced with estrogen and would cause infertility. And I mention this because this is coming up again today. So these myths circulate around the world even before social media was there. Which groups are most likely to be vaccine hesitant and not get it or definitely not get it? You can see the list there from the Kaiser Family Foundation, who does regular polls, and I'll highlight much of their work during this 20 or 25 minutes. We also want to see that 35% of Black, 26% of Hispanic. But really what I want to focus on is your teams, your colleagues that you work with on a daily basis. A third of them will definitely not, or probably not, get vaccinated. Now, many of these are in nursing homes, and not necessarily in hospitals that many of whom are mandating. But we know that only 4 in 10 have not been vaccinated, and almost 20% do not want to get vaccinated. And we have much more influence over our colleagues and our team. So when I talk about the team, I'm talking about the receptionist, the transporter, your medical assistants, your nurses. These are trusted workers that many of our patients relate to more than they relate perhaps to the physician or the advanced practice provider. Looking at people who already got vaccinated, let's highlight the good news. Millions and millions of people have gotten vaccinated. The definitely not group, interestingly, has not changed. And there you can see the total is 14%. It was 15%, and historically, it's always about 15%. And generally speaking, these are people who do not believe in science. Their heels are dug in, and no information at all will change them. So we're not going to focus our messaging on them until we focus and are effective with our messaging for the wait and see group. And the wait and see group are the Black and Hispanic people of color, as well as the 18 to 29-year-olds. And you'll see some surveys to talk about who they are and what the messaging is most effective in those groups. The wait and see group are more likely young and people of color, and the definitely not group are Republican leaning and rural. The good news, again, is that half of those in January who were in the wait and see group have gone ahead and gotten vaccinated. Now, most people want to be in the majority. So telling people who are still in the wait and see group that many of your patients, or most of the patients that were being thoughtful back in January, have decided to get the vaccine, and they all did very well. They didn't have any, but they were being thoughtful and conservative, and you honored that. And hopefully then you'll engage those patients of yours or those acquaintances of yours, make them see that it was okay to be in that group, that wait and see, and that the majority of that group has gone ahead and gotten vaccinated. This is true for our LGBT community as well. I'm going to break this down into the pro-vaccine, the hesitant, and the anti-vaccine. We're going to focus most of the time on the hesitant group. But think about the people who are pro-vaccine. There are people in your community, people on your healthcare team that are very pro-vaccine. You want to engage them and empower them to be ambassadors. I recall one of the most effective ambassadors in my practice on the west side of Chicago was the pastor of a very large African-American church, huge church. And he had a new grandson, and he shared that with me. I was taking care of him for over 20 years, he and his family. And I said, oh, well, then you need to update your Tdap, your whooping cough. And he said, oh, absolutely. And we talked about whooping cough. And then just as he was about to leave, he said, Doc, we baptize about a dozen newborns every weekend. Should my deacons get vaccinated as well? And I thought, oh my gosh, he probably, because he encouraged his deacons who would have been holding these newborns and having an opportunity to talk to their parents, decrease the pertussis rate on the west side of Chicago single-handedly. We're going to talk briefly about the anti-vaccinationists just from a historical perspective. These are often called non-science-based sites so that we don't want to antagonize any more than we feel that already. But we also have to remember that many of these non-science-based sites and the anti-vaccine movement was because of physicians. And these are four very influential physicians. Many of you know Dr. Andrew Wakefield. He's been, his license was suspended years ago in the UK. Mercola, Northrop, and Brogan. These are MDs or DOs who are trusted and have great influence. If you and your team, and I really want to recognize the team, your receptionists, your MAs, your nurses, everybody on the healthcare team, look at this very brief article that was published in 1998, took 12 years to retract it, and this is what started the false association between MMR and autism. So in our residence group, our medical students group, this should be taught. He was stripped of his license in the UK, and he did not disclose that, and it was only 12 children that they were already involved in a lawsuit, many of them looking for somebody to blame for their sad children's developmental disorders. But the damage was done, and a fog of suspicion cast upon all vaccines. And I will confess that when I first heard this decades ago, I thought, oh, my poor pediatric colleagues. But it really has caused a fog of suspicion on all vaccines. So this is something, whether you're a surgeon, a psychiatrist, we all need to pay attention to adult vaccinations. And we all need to say with great authority that there is absolutely no link. And if you can't say it with great authority or your team doesn't, look at some of the website, look at the immunize.org so that you can answer and feel knowledgeable enough to convey it with authority. Some of the current conspiracy theories and lies promoted by some of our colleagues who are physicians. The most recent one is vaccines have been the COVID vaccine to depopulate the world, and the more vaccines you get, the more likely you are to die. This is what our patients are hearing. This is the pandemic. You can see that she had 500,000 Facebook followers. This was a physician in women's health, discredited, not science-based, but extremely effective. And the movie was taken down, but it was called The Plandemic. One version of that theory is that it's part of a strategy by global elites to roll out vaccinations and activated that there's a tracking chip and could be activated by 5G. This led to towers in the UK being damaged. We really need research on understanding this campaign, understanding this information disorder. It's not all the same. On the far left in the center graphic, you see misinformation, incorrect statements, all the way to people who are intending to harm. And these are trolls, and these are magnified automatically by bots. And we need to understand this and how effective they are. On the far right, you can see that spectrum. So at the very top, high harm, there's absolutely an intent to deceive, sometimes manipulated so that they can sell you a product, which is what we see some of our colleagues and physicians doing. Some parodies that were meant to be funny were taken out of context, and they were not received as tongue-in-cheek, and then also did some harm. So we need to be careful about that too. When you repeat a myth, if it's repeated often enough, a lie becomes the truth. So be careful, as we've learned from the government in crisis management, to be careful not, when you're talking to the public, to restate the myth, because sometimes that's all they hear. Not that this myth is false. They may not hear the false part, but they hear the myth, because that is so much more compelling. But we really want to focus on the hesitant. Most people want to get along, go along. They're busy. They have a very busy life, children to take care of, bills to pay. And this is where the mandates are very effective. If we make it easier for them to get through the day if they're vaccinated, and put some barriers in front of them and make it more inconvenient to be unvaccinated, that is very effective. And we know that vaccine hesitancy, one of the top 10 threats. So most patients want to do the right thing. When they don't understand what to do, they go to social media. Telling them not to go to social media is not the right direction. And telling stories is. And we'll talk about how we are taught often in medical school not to tell stories. But the CDC and some of the stories that I'll share at the very end are from the CDC. And anecdotes and metaphors and stories are very important, and we need to use them. So let's talk briefly about how these spread. And we all know the billions and millions of opportunities. And this was before COVID. It grew because we were all in lockdown and isolated. And anti-vaccine tweets, even before 2016, were 4 times more likely to be retweeted than pro-vaccine, and that's part of the problem. But this is big business. So the social media firms are receiving billions of dollars. Entrepreneurs like Joseph Mercola are proposing myths and then selling products to counter the misinformation that he is very effectively promulgating, with a very good system and lots of staff to do that. So this could be an infodemic. And it looks like it's going to be, and if we don't get control of it, there'll be more anti-vaccine sites than pro-vaccine. Just to finish up, highlighting a very elegant study looking at 100 million Facebook pages and seeing why this is, when there are more pro-vaccine people than anti-vaccine people. And I think this is a very beautiful graphic to demonstrate this. This is global. Looking at that 100 million. The green are undecided dots, specific sites or Facebook pages. The blue are pro-vaccine, and the red are anti-vaccine. And as you can see, there's almost twice as many pro-vaccine, but the anti-vaccine, the red, are much more effectively entangled. So there's more separate ones, and they're more effective. While the blue, the pro-vaccines, we're talking to ourselves, and we have a false sense of security that we're being effective. So we need to move where the red dots are so that we can influence and counter the lies that are out there from the anti-vaccine or non-science groups. These platforms appear more mainstream for that reason, even though there's half as many, and they're extremely effective. So what are some of the myths that we're hearing? These are just going to list them for you. And again, the majority of people have heard, and they don't know if it's true, one of these, or they believe it's true. And who are these people? Well, they're across the board. They're Democrats, independents, and Republicans. Now, they don't believe all these myths, but they believe one or more, and either believe it's true or think it might be true. One that I'm going to highlight, most of these myths we're going to talk about in the Q&A, worried about taking the vaccine during pregnancy, or people who are trying to get pregnant. We do know clearly that if you get COVID when pregnant, the damage is real. Poor pregnancy outcomes, pregnancy loss, preterm delivery, and more time in the NICU. I'm happy to share, with permission from my daughter, that she got her vaccine during her 2nd trimester, had a healthy baby 2 weeks ago, and we're so thrilled that that baby who is perfectly healthy is now has some passive antibodies and is somewhat protected. So sharing that story, my story, that my daughter got vaccinated and the baby and mom and dad are very healthy, is key. So let's go back a little bit and understand why patients are vulnerable and why even our teams are vulnerable to some of these myths and where we fit in. If you are not familiar with, as I was not, with the Tuskegee study, please watch a movie, read very briefly. It'll take you about 5 minutes, but it's summary. 1932 farmers with syphilis were enrolled in the study. Penicillin became available, and it was not used to treat these men. The real crime here is that 40 years later is when these men were given treatment. Sadly, this was published in the 60s, observing untreated syphilis for 30 years, 20 years after syphilis was available. In Puerto Rico, the pharmaceutical company wasn't able, there was resistance to do drug trials for the pill in the continental United States, so they went to Puerto Rico, and they were not told that the patients there that it was experimental or had potentially dangerous side effects. So these hopefully slides will be available to you. We need to look at our own biases, take our own responsibility. It's easier to gather our teams together. Ask your teams, your MAs, your non-physician members of your team what they've heard. I found that if I asked my patients or my team, what have you heard from your community? They're more likely to be straightforward because they know how you feel. You're pro-vaccine. So they're going to be very hesitant or embarrassed to tell you what they believe, but they might couch it in, well, I have heard in my community. And there's a video where I interview my patients that is open access for you that I'll show at the last slide, where my patients say that I have heard that it could cause infertility. So you'll find out what they're hearing, and they may couch it that it's not them, but probably they're worried about it as well. And using storytelling and imagery is critical. So it's easier to change you and your team's beliefs before you can change all of the American population's beliefs. And then we have the same tailored message. And when I talk about this, it's not it's the pathologists, it's our psychiatrists, it's our surgeons, our orthopedic surgeons, everybody who touches, because they are trusted by our physicians. Many of us think that these patients are difficult, and it's not our responsibility. We get angry. You know, I'm doing my job. I am exhausted here. I am burned out. They should just trust the science. Well, if we have that attitude, we're not going to be able to communicate effectively. So let's look inwardly, see how we can calm ourselves and our teams down so that we can have more messages. And I'll highlight some of those opportunities with some case studies. You can use a physician belief scale that gets to whether we think our colleagues or ourselves feel that addressing individual thought and behavior is our responsibility. And if it's your team, if you do this and you see some questions that are asked here, if they on a Likert scale don't agree with this or agree or disagree, you'll find out whether your team is even in the right mental state to have these conversations about patients' individual thoughts. Because if we don't respect the individual thoughts or feel it's our responsibility, we're not even getting off the starting block. I would also refer you to the Center for Countering Digital Hate in London. And here the CEO says we have to stop people from becoming anti-vaxxers because we have to think of this as a contagion. Here's an open access, an example of a digital toolkit that you can use, copy the tweets, copy the Facebook pages, engage somebody, maybe a young woman who's a new mom in the conversation at your, on your team, or maybe a neighbor or a niece or a daughter. Give them the tools that they can put on their website to counter what they're hearing, because we're not entangled in the undecided. Wear a button. If everybody in the hospital is wearing a button that says, I got my COVID shot, doesn't take any extra time, but it sends a clear message. My daughter and son-in-law were just at the hospital delivering a baby, and they said that and then a follow-up visit, they probably were touched by 30 healthcare providers. Not one healthcare provider asked them if they got their vaccine, where hopefully would follow with, well, there's a clinic right on the first floor, you can get it. But 30 missed opportunities to state the importance of it, because you're trusted and you're and this young couple at a vulnerable time, right? Just like we did with whooping cough, and we really engaged our OB/GYN colleagues. So storytelling is really hardwired into our humanity, and we really need to use those stories, and I'll show some here. Let me just go ahead. Remember, you are the most trusted source of information. So I want to empower you and your colleagues. Sometimes we forget the great influence we have on our patients. This is true for Republicans and Democrats as well, because they trust you. You've gotten them through, maybe a cancer, a heart disease. Our cardiologists, everybody needs to be giving the same message, strong message. Saying nothing is saying something. So every time there's a touch with a patient, we need to take that opportunity to talk to our patients. Knowledge is incredibly important. We're going to clear up some of the myths or provide you with responses to them. And you may be the most knowledgeable person and physician. You'll be respected, but if you don't have the time to show that you care, you won't be trusted. Similarly, you can show you care deeply for your patients, but if you don't know and dig down into the source of the myths and how to counter them, they'll love you, but they're not going to trust you. So both knowledge and caring are key to developing trust. And for our hospital administrators, trust takes time to develop if we're really going to get those vaccination rates up. And it may mean adding on an extra few minutes to that visit so that we can develop that trust, that interpersonal relationship. It doesn't happen without time. So here's a couple of case studies that are in the Steps Forward Toolkit at the AMA, which is open access, don't need to be a member, don't need to be a physician. Patient might come in and say, what do you think of hydrochloroquine? You might have very strong opinions about hydrochloroquine, but it is advisable not to answer immediately. Say something positive. Oh, you're worried. You're looking for something that'll help you prevent infection. Open up the door, start a little conversation. It will only take maybe 20 or 30 seconds more, but a quick response, yes or no, shuts down that patient for the remainder of the visit. That's not what we want to do. So we have to control our own frustration and sometimes anger, and not answer immediately. And then when they're ready, say, could I share some information about what I think? And if they say yes, it's going to be a much more effective message. Last case study, somebody comes in and says they're not wearing masks. It causes, it's unhealthy to rebreathe carbon dioxide. You may not agree with that statement, but you can still show empathy. That person wants to be safe. So you can say things like that script, you'd like to be safe, you'd like the freedom to make choices that you feel are safe. You're not agreeing with them, but you're showing empathy, and you're going to keep that door open and hopefully move that patient to the vaccinated category. What are the most effective messages for the wait and see? They're listed here. It's 100% effective at preventing hospitalization death, clear and concise. Don't use necessarily the reference literature. The technology's been around for 20 years. And then when we look at the wait and see group, waiting for full FDA approval is very effective. So telling people, if they say no, say, I understand your concerns, you're being very thoughtful, that's great. How about we talk about the vaccine when it gets FDA approval? Just keep the door open. Don't look for a no. If we are giving the message that this is part of everyone's responsibility, then we are missing half of our audience. So we don't have to agree that it's a personal choice, but we have to respect that it's a personal choice and not lead with that. You can say, I understand you think it's a personal choice, and then go from there. So let's look at some of the trusted resources that many of our vaccine hesitant patients and colleagues and citizens and Americans are looking at. Fox News and Breitbart, they trust these media sources. These are screenshots directly from those sources where Trump says, I would recommend it. Many people don't know that he is on record as saying this. And he confirmed that he got his first shot in January, as did the First Lady. This is a transcript from CPAC. Everyone should get the vaccine. This is what Donald Trump said. Direct them to this and make everyone aware on your team that this has been said, if this is the trusted resource that people look toward. And for the evangelical community, which is also not vaccinated as high as we would like, this is Billy Graham's grandson, who's now the CEO. And he says, vaccines bring healing to bodies like Jesus did. So look at these sources that are trusted and make them aware of the people, to the people who are only listening to these and use these as trusted resources. For our Catholic community, which is heavily Hispanic, Pope Francis has said it's morally everyone's responsibility. And at the end there is even the statement from the Vatican document addressing fetal stem cells and voluntary abortion, and that the use of vaccines does not signify any sort of cooperation, and that is the responsibility to take the vaccine. We know that Pope Benedict and Pope Francis, they're online. You can show pictures in your office, screenshots of them receiving their vaccine, and the Vatican has mandated vaccine for the employees at the Vatican. Another message talking about other people in the family getting sick is effective across the board to all the people in different camps. So people in the United States are very generous. They're more likely to take a vaccine to protect somebody in their family than for themselves. So use that. They don't want it, they're healthy. Do you have a grandma that you love? Oh, how old is she? Oh, well, you could protect her. And more often than not, when I had a conversation with a 30-year-old young man, he loved his grandma. He would do anything for his grandma. He said, all right, give me the flu shot. The same can be said for the COVID. So again, strong responses. You cannot get the COVID from it. You can use this sort of metaphor. I said this to my team, when you give the flu shot, tell the patient this will not prevent the common cold, because as you know, many of you here, when I got the flu shot, I got the flu. So at the beginning, before that cold occurs, the common cold, tell them it doesn't prevent the common cold. This is another metaphor direct from the CDC, using fables or stories to talk about patients who are saying, oh, if everybody else gets immunized, I won't need to. Similarly here, I'm healthy, I don't need it. Use the example of a fire extinguisher. If everybody else gets vaccinated, I won't need to. Well, that's true also if you're a safe driver, do you really need the seatbelt? So use things that make sense. Again, use it with your team, and they will be able then to use it with their family and the patients. I'm going to summarize by showing a couple of resources. This is a video that is a very interesting lunch and learn for your team to watch together. You'll see many of these are my patients sharing why they refused vaccines. And I think you'll identify, and your team will identify with many of them. Again, you are the most trusted resource, your own doctor, and for parents, their child's pediatrician, far and above anybody else. Patients want it in their own doctor's office or in their local pharmacy. This is a problem with access if people don't have a primary care physician. And all of us and all of our colleagues, the orthopod, the psychiatrist, the general surgeon, the neurologist, the cardiologist, we need our colleagues to say, be sure you get your COVID vaccine. These are another couple of resources, and I'll end here and send it back to Dr. Benson to answer some of those wonderful questions. Thank you for your attention.
Well, that was a true tour de force and giving us all really creative and impactful advice on how to talk to patients about this issue. And there are obviously several comments in the chat about wanting access to the slides and the presentation. At the end of our program, our IAS-USA staff will tell you how to access that information and those slides. So we are going to go straight into Q&A.
Oh, and Dr. Benson, I forgot to ask if you could put the listeners in the chat box, any of the myths or anything you hear that patients are telling you, that would be very helpful to inform us and the next time we talk about this.
Okay, so my minders are telling me that we need to do our post-test questions.
Oh, that's right.
So
I think that, can they pull it up?
I think Jose will pull them up.
Okay, great.
So the first post-test question, as you saw at the beginning, who do patients trust most regarding vaccinations? I think you all got the message on this one. We'll give you a moment to answer the questions and show you the answers. Okay. So at the beginning, it was 97% of you thought it was physicians and healthcare practitioners. Now it's 100% of you. So that's great information. You got your point across, Marie. And our next poll question, Jose. So true or false, most of the wait and see group of patients have received a COVID-19 vaccination. Okay, 89% of people believe that's true and 11% false. And I think when these questions were prepared, the answer was probably false. They hadn't, but I think things have moved quite substantially in the last week or so, given all of the media attention to this issue. So I think a lot of the wait and see people have been pushed off the fence a little bit, but we still have a lot of work to do. So I'm going to start with the questions that came into the Q&A, but then move quickly on to the really rich number of questions we received from our colleagues in advance of today's conference. So one of the questions that came into the Q&A was, how can we best address vaccine hesitancy in light of the recent CDC study in Massachusetts showing that more than 70% of those in that outbreak in Massachusetts were people who had been vaccinated. Do you have any thoughts about that, Marie? How would you approach the messaging?
Why don't you go ahead and take that one? I think you're...
Okay, this actually will cover a lot of several of the questions that also came in advance of our webinar today about what's happening with vaccines in people who've been fully vaccinated. And I think what's the biggest point I want to get across is that a lot of the messaging that's gone on about this has been confusing. And I think the reason it's been confusing is because the media and even many of our colleagues who talk on the news have not been making this distinction between being infected and able to transmit the infection versus having severe disease, being hospitalized, or having a high risk of dying. And I think all of the vaccines that are available to us right now are extremely effective in preventing severe disease and preventing hospitalizations and preventing deaths. And I can use an example from my own hospital right now. We're in the midst of a surge here in San Diego, where we've had a 200% increase in the number of people hospitalized with COVID in the last week. And Of those individuals hospitalized with COVID, over 92% of them are people who were not vaccinated at all, had not received a single dose. Fewer than 10% of those who were hospitalized had received vaccinations. Half of those were only partially vaccinated, but none of the ones who were vaccinated are in the ICU. All of the people who were hospitalized in our institution and are in the ICU are unvaccinated people. So the point there is that the vaccines are exceedingly effective in preventing serious, severe COVID disease, preventing hospitalization, and preventing death from COVID-19. What we know about the Delta variant in the surge that we are in right now, over 50% of the cases in certain areas and over 90% in other areas experiencing large surges are from the Delta variant. And people who have been fully vaccinated are able to be infected, but they are not developing severe symptoms of COVID disease. So when you see the news reports, when they talk about a big outbreak of COVID disease in Massachusetts among people who've been infected, the majority of those individuals do not have symptoms at all, or they have mild symptoms and they were only tested because they were in the midst of an outbreak. So that does not mean that the vaccines are not effective. It actually is an advertisement for how effective the vaccines are in preventing the majority of those people from getting sick and from being hospitalized and from dying. So I think that's the message about that vaccine outbreak in Massachusetts. So,
and I would say that you modeled exactly the response, which is, it is confusing, right? And that's where the opportunity when you're talking to somebody to honor what they're experiencing, because they're hearing a lot of things from a lot of trusted resources and they want to do the right thing. They just don't know what to do. So I think modeling that, that's a really good question. It is confusing, and then going into the data is the most important communication strategy there.
So I think this one you touched on a little bit in your talk, Dr. Brown, and is an important point to make. How do you convince your daughter who's in the third trimester of pregnancy to get vaccinated? And a corollary to that, how do you encourage breastfeeding parents to be vaccinated?
Well, that's a great question. And I did not convince my daughter, who is not in healthcare at all. She went to her OB during her second trimester, and the OB said, get the vaccine. And he said, my wife got it, and used an anecdote. And that's all she needed. So it was a trusted person who was caring for her for something else. And she went right out and got it. So she didn't even have that discussion with me. So it was the obstetrician who was caring for her. Really, really powerful.
And here's another question and I think makes a very good point. So why are we calling this vaccine hesitancy when people are refusing to be vaccinated? Hesitant makes it seem like they're not sure if they want the vaccine. I think you talked a little bit about this point in your talk as well, Dr. Brown. So is our terminology wrong? Should we be talking in a different way about vaccine hesitancy, as we're calling it?
Well, I think hesitancy is a good term because we want to move them to vaccine acceptors. That 10 to 15% that are refusing vaccine will always refuse vaccine. And as I said, even back in smallpox, the term conscientious objector was a phrase coined when people refused to take the smallpox vaccine in London hundreds of years ago. So we're not going to change that number, and it's consistent throughout history. But what we want to focus on is the vast majority who are in the hesitant group. They want to do the right thing. They need a trusted person, like people on this call, to be knowledgeable, to respect their concerns, and answer their questions, and they trust you.
And here's another question kind of related to people who have been vaccinated. How likely are they to get infected with COVID? So I think there's one of the questions is, will 100% of non-vaccinees get COVID if they don't get vaccinated? I think that question clearly depends on the risk of the person and who they're in contact with. The Delta variant, I've developed a tremendous amount of respect for how transmissible this current circulating variant is. And if that individual is not vaccinated at all and comes into reasonable contact with like a household or family member, or indoor contact for any period of time where they're close to other people carrying the Delta variant, there is such a high viral load in the nasal secretions of people who are infected with the Delta variant that it's very likely that they will become infected if they're not vaccinated. For people who've been vaccinated, we don't know the true answer to that. There's actually an ongoing large NIH-sponsored trial of how easy is it to become infected after you've been vaccinated. We know that if people are at high risk, and what we're talking about as high risk at the moment are people who are immunocompromised or who are over the age of 65, who may not have as robust an immune response to any vaccine as people who are younger. They may be at a little bit higher risk of getting infected, but they are not at a higher risk of getting serious disease. So I think the point here is that 100% of people who are fully vaccinated will not get infected if they encounter the Delta variant. It's still a pretty low percentage of people, but there are certain outbreaks like that Massachusetts outbreak where they were able to track a high rate of infection, but not a high rate of serious disease. And that's the point to keep getting across. Another myth that one of our audience asked about was a false notion circulating in the news, stated by a former Nobel laureate, that all vaccinees, people who have received COVID vaccines, would die within 2 years due to antibody-dependent enhancement. I think you had that as one of the myths on your slide too, Marie. And so antibody-dependent enhancement after vaccination was a very early concern of our scientific community when we started looking at coronavirus vaccines. Some of that was related to the experience with very early coronavirus vaccines in veterinary practices, where early on, a few animals did develop antibody-dependent enhancement and actually got sicker after encountering coronavirus after they got the vaccine. We have been tracking this in the scientific community ever since the origin of the first SARS-CoV and MERS outbreaks. There's been no evidence in any of the human studies that antibody-dependent enhancement has occurred. And certainly there's been not a single case reported out of the multi-millions of people who've been vaccinated now. The idea that 2 years from now that would happen, there's no evidence to support that. And I don't think that that's a valid concern about the current vaccines. Can we say that with any certainty? I don't know how you answer those kinds of questions, Marie, when it's a not answerable question, but it's oftentimes something that's thrown out there. Well, you can't say it couldn't happen if you don't know that it doesn't, right? How do you address that kind of a conversation?
Well, I think you pivot quickly to what we do know, and that when I think I mentioned this quickly, but I'll highlight it. When you're trying to get somebody to do something, it is more effective like the opposite. If you're trying to get somebody to stop smoking, telling them what bad things can happen, emphysema, lung cancer, that's effective. If you're trying to get somebody to do something, like get the vaccine, highlighting the benefits of it. Do you want to get back to work? Do you want your kids to get out of your house and go back to school? Do you want to be able to hug your parents and see your brothers and sister? What are you missing now? Maybe they've lost their job. So highlighting the benefits, the good news that if you got vaccinated, this is what would happen. Because if the anti-vaccine movement will find that tiny little nugget, and you can't prove, we don't know, we can't possibly know that answer, right? It's impossible to know that answer about what will happen 2 years after the vaccine. We cannot predict the future. So pivoting quickly to the benefits of getting the vaccine, and that it's so safe, and remembering polio and remembering measles and the encephalitis and the brain damage that occurs with that, and what would happen if you got COVID when you're pregnant, or share the story of the last patient you saw. Tell them they were a school teacher or your neighbor, whatever experience. And the people on this call, can't thank you enough for your work, but the most heart-wrenching story of somebody who died of COVID, that they lost their mother, their sister, their wife, whatever. Share that story, and tell the heart-wrenching story about somebody who could have prevented their death had the vaccine been available. And thank God we have the vaccine now. So, pivot to, tell an anecdote about a patient that you lost, or a story that you are aware of, to communicate the benefits of the vaccine. That's how I would answer it, Connie. A lot of questions on infertility I get, because that's that young group, and a lot of healthcare workers, right? Young nurses, dental assistants. And how do we respond to that, along with the DNA question? Because there's something about DNA that I hear about these vaccines.
So I think the infertility question came up in our pre-webinar questions as well. Several people submitted that question, and I think it's important for us as healthcare workers to address it. And using some of the tools you just talked about. In fact, there is very strong evidence that with the overexpression of the receptors for coronaviruses in testes, it's far more likely that male infertility in particular is a complication of COVID disease, not of vaccination. And that people who get COVID, even if they don't have severe COVID, there's the potential for COVID in the testes to result in decreased sperm counts, decreased semen quality and volume, and short-term infertility in men is a well-described complication of COVID disease now. There are multiple references. If anyone in the audience would like them, I'd be happy to email you the references. But and there's not a single reference related to any impact on the male or female reproductive system in animal models or post-vaccination related to evidence suggesting infertility. So all of the infertility data related to COVID is all in the direction of that being a complication of getting COVID, not of getting the vaccine.
Yeah, and likening it to mumps, I think, is a similar for our coworkers and people who are not pediatricians. We all remember that mumps could cause orchitis and infertility, so that would make sense to somebody. So I think that's a really good message there.
So just kind of building on that question, multiple ones that came in from the audience related to the issue of boosting and whether we're going to need, how effective are these current vaccines and against variants, and will we need boosters? and how durable is the vaccine protection. So these are all extremely insightful questions that I think are the focus of numerous studies at this point in time. What we can say based on our current information is that all of the vaccines are extremely effective against the current variants. Now, what do I mean by extremely effective? And I made this point earlier. They are extremely effective in preventing severe disease, preventing hospitalization, and preventing death. They are not as effective in preventing people who are fully vaccinated from getting infected. So this is the part and parcel of the CDC's recommendation this past week to go back to masking in indoor settings where there's a lot of circulating virus, particularly the Delta variant, and having everyone mask indoors. And I think that's an important piece of information. So again, people who are vaccinated can protect themselves from severe disease, from hospitalization, and from death by being vaccinated. But there is still the potential, although not as high a potential as the unvaccinated, that they could be infected and transmit to another person. So that's where we are with understanding vaccine efficacy. What about vaccine boosters? And this is another frequent question that came in from the audience. I think the messaging from the CDC has been a bit too conservative. Those of us who have been working with the COVID vaccines in the clinics and in clinical trials are understanding that we do see a waning of the neutralizing antibody response over time. What I can say is neutralizing antibody responses with the current vaccines still are above the threshold where most people get severe disease, even after up to 9 months now after vaccination. We started vaccinating people back in clinical trials last summer and in clinical practice back in December. And so we have 9 to 12 months of data now that show the majority of people still have neutralizing antibody well above the threshold that that we know will prevent severe disease. However, I think the messaging that is becoming apparent from what we're collecting in clinical trials right now is that there are vulnerable populations within the fully vaccinated. And those are individuals who are immunosuppressed, individuals who are elderly over the age of 65, and they appear to be those individuals who either had a less robust early response or are having a more rapid waning of immunity than what we see in younger, healthier individuals. And I think we're going to see recommendations from public health officials in the very near future that vaccine boosters will be necessary. They're likely to prioritize people over the age of 65, people who are immunosuppressed or have recently been immunosuppressed, or people in other high-risk categories. And we know that some countries now, Dr. Brown and I were talking over the weekend, in Israel has already started to do that as a matter of policy for their citizens. So I think we are likely to be headed in that direction for vulnerable populations in getting a booster dose in the fall. But we will have data from clinical trials of the newer doses of vaccine to see whether they are newer vaccines that also cover the variants, to see whether that will be necessary with second generation vaccines. There's a question here kind of following on that about whether it's safe to mix vaccines. And the answer to that is, based on current evidence, yes. Some countries have already begun to do that when they had short supplies of certain types of vaccines. They've gone to the second dose of vaccine or a booster dose of vaccine being another type. For example, the adenovirus vector vaccines are now being boosted with the mRNA vaccines in some countries, and vice versa. First dose of an mRNA vaccine is now being boosted with an adenovirus vaccine, and those appear to be safe in clinical trials, and some governments are rolling that out in their countries. So I think that is safe. Here's a question. You started to address it, Dr. Brown, but maybe you could say a little bit more about it. Do you have particular messages about talking about vaccine hesitancy among your Black population or Hispanic populations? Are there tailored messages that you have advice about for African American or Black or Hispanic populations? No, I think you're muted.
I think the website I showed, La Conversación, I'm ruining the accent there, will have celebrities and trustworthy sources that will address some of the concerns. I think being aware, and it's pretty easy to have a 15-minute discussion or grand rounds on things that have happened historically, so that we come to those conversations and those relationships with our patients. And when we enter that community, we are humble and aware that the Tuskegee study was funded, for instance, by the US government. So the concerns are similar. The historical perspective may be a little different, and I think that's up to us to understand it and to teach it and to honor it. And I don't know if you noticed, but hopefully you'll look at these slides again, or we'll send them out to you, that saying that 100,000, more than 100,000 participants in the initial clinical trials represented minorities. I don't know, Connie, do you have any other specific?
No, I think you made a couple of very good points about some of the church leaders in African American communities. The story about the deacon that you talked about, I think making use of representatives of their community is a particularly important message that I've heard about and that I've often used when I talk to people about this issue, trying to have a champion, if you will, of vaccination. Again, before we started off the webinar, I was reading an opinion piece in one of the newspapers and talking about the fact that we often have turned to celebrities to support certain issues. And for this, there have been a number of celebrities who actually have tremendous influence over Black communities and Hispanic communities who have had a real hands-off approach to the whole issue of vaccination. We're starting to turn that around a little bit, but I think some of those messages are starting to get out more effectively with people that they listen to. So,
yeah, another myth that popped up was that that when you go to get the vaccine, they requested documentation, which would cause some members of the community who do not have papers, and given the last administration, hesitant to show up to a government site that was doing that. But so that's where access for the hesitant, having a mobile, going to the place of work, going to where migrant workers might be working, making it easier, putting a mobile station in front of a concert so that you can get in if you get the vaccine. If it's inconvenient for that young group, the 18 to 29, all right, I really want to see that musician, I'll get the vaccine. So that's where access, making it more convenient than inconvenient. And especially when we get to school, we learned this from, and California went through this, mandating school vaccinations. And the American Academy of Pediatrics has a wonderful document where you can ask the parent to read all this, which says lists all the things I understand that not vaccinating can lead to, and all the negative things, including encephalitis and death of my child. I understand, and I still decline. That usually changes a parent's mind when they have to do something. So making it more convenient to be vaccinated is important, and making sure that we lower any barriers and address the myth that hopefully nobody's requiring documentation, because the vaccines are free. And some of the other concerns, I think, were the DNA, I think, and the heart concerns that some people have. I don't know if Dr. Benson, in the few minutes we have left, if you wanted to address any of those.
Sure, I can. I'd like to talk about just a couple of things. There were several questions from the registrants about whether we have any evidence post-vaccination of adverse pregnancy outcomes. And I just wanted to highlight a couple of pieces of information. So the CDC and the FDA are both following pregnant women who have been vaccinated through the Vaccine Adverse Event Reporting System, often referred to in the news media as VAERS, VAERS. If you look it up on a website, you'll come directly to it. And based on data that they've collected from over 120,000 pregnant women who reported receiving vaccine during pregnancy, there's not been a single adverse outcome among the pregnant women or their infants up to this point in time. And this is through data collected as of May 24th, 2021. So this gets updated regularly. There have been pregnant women who received COVID-19 vaccines who miscarried, but the miscarriage rates among those women are the same as in the general population prior to the pandemic, or in the general population who have not received vaccination. So they will continue to be collecting that information and will be updating it regularly. We also have animal toxicity studies that are regularly used for vaccine development, given the SARS-CoV-2 vaccines during the early or late gestation in multiple animal models have shown no effect on embryonic, fetal, or postnatal development of fetuses born to those animals after receipt of vaccines. So I think we feel pretty comfortable at this point in time that the vaccines are not associated with adverse pregnancy outcomes, in contrast to COVID itself, in which pregnant women are at increased risk of more severe illness, increased risk of ICU admission, increased risk of the need for mechanical ventilation, and have a higher mortality rate associated with COVID than non-pregnant women. Infection earlier in pregnancy is also associated with an increased risk of adverse fetal outcomes. And in a meta-analysis that included over 42 studies involving almost 500,000 pregnant women who got COVID, the adverse fetal outcomes that were recognized at higher rates than in the pre-pandemic era were preeclampsia, preterm birth, and stillbirth. So it's far more dangerous to get COVID if you're pregnant than to get the vaccine if you're pregnant. And then the reports of some of these more serious complications of vaccines in young people, in particular myocarditis. There is an ongoing follow-up series of young people, and it does appear that the mRNA vaccines have been associated with an increased risk of myocarditis. In the cases that have been reported have been predominantly male. The rate or prevalence of infection is about one case per 7 million doses of post-second dose of vaccination. It appears to be more common after the second dose of the vaccine and more common in males and more common in people under the age of 30. Of the reported cases, according to the MMWR and the CDC, only a minority of them have required hospitalization. They've all been self-limited infections. All of the people who've developed them have recovered. The myocarditis has been relatively mild and primarily associated with chest pain, low-grade fever, and sometimes symptoms of shortness of breath and pleuritic chest pain. And most of those have been associated with modest EKG or ECG findings of ST elevations. But again, most of them have resolved completely within 5 to 7 days of onset. There have been no deaths related to myocarditis following vaccination. So that's one of the things that we do know. The thrombotic thrombocytopenic purpura that appears to mimic heparin-induced thrombocytopenia. We have about 17 cases. Those have all been in people who have gotten an adenovirus-based vaccine, and that appears to have a predilection for women as opposed to men. And there have been 3 fatal cases of cavernous sinus thrombosis among younger women who received an adenovirus vector vaccine. But again, the incidence is about, it depends on the age group that you look at, but again, it tends to be younger women under the age of 30. And there have been the cases that have been reported thus far in the United States, mostly due to the Johnson & Johnson vaccine, most of those have resolved with treatment in the hospital and have been only 3 deaths, and the overarching rate at which that has occurred is approximately 1 in every 7 million doses. So kind of similar to the description with the myocarditis. So it's an extremely rare complication of vaccines, maybe a little more common in younger individuals, but most of these have been, once they're recognized, adequately treated or resolving.
Let me just add that the numbers, because we love facts. These numbers, 1 in 7 million, are meaningful to the people on the call, yet may not be as meaningful to the general population. So answering that question in somebody who doesn't have a science background, and saying, well, it's only 1 in 7 million, they may have just come from the local gas station and put $20 down on a 1 in 10 million shot of winning the $1 million lottery. The average American spends $200 on the lottery every year. So responding with small number, and those who did get it, it didn't last long, and they're fine. And especially if you have a personal history or you know more details about a case, so responding with the narrative and then following with, and I had whoever the person is, a 20-year-old who's asking you the question, or the mother, we had a 20-year-old just last week who passed away after 3 weeks in the hospital, intubated, or whatever story that you can get, that the disease is so much worse. But responding just with numbers, we know, is not terribly effective for people who do not have a science background.
Right, not an effective message.
Yeah.
So a couple of questions in the Q&A, just following up on some of the information we've given. We don't have enough time post-vaccination in following these patients who've been vaccinated, whether there may be longer term effects on newborns. So do we have any good answers for them? I think it's kind of like the 2 years post-vaccination. How do we know we'll never see a long-term side effect? Do you have a good answer for that?
No, I think pivoting right away to what happens, we know what happens when you get COVID. And trying not to repeat the myth, what we've learned from crisis management from the government, is important. And just sharing what we do know and telling it in a narrative and listening very carefully to what the person's concerns are. Again, you don't have to agree with them, And you're not going to tell the man who says the masks, rebreathing carbon dioxide is going to kill me. It's worse than COVID. You can be empathetic with that gentleman or whatever myth you hear. And then only when you show empathy and respect, reflecting that they're concerned, they care deeply, honoring that, and then they're going to be more receptive to whatever message you can give them.
Okay, another question that came up and comes up frequently to me and comes up on the news media all the time is, what's your best answer to someone that says the vaccines are still experimental? They haven't been approved by the FDA, so why should I take them?
You want to answer?
Do you have an answer? Do you have a good answer to that one?
Well, I think it's my answer, and you know the literature better than I. These have been very well. They're very safe. They've been evaluated. The research has been 20 years in the making for these. Is probably going to change how we give vaccinations or develop vaccines in the future. And we do know with the messaging from Kaiser.
Yeah, and I'd be happy to talk a little bit more about that too. So I'm getting a message about unstable internet, but I think you can still hear me, Marie? Okay.
Yeah.
So I think the best answer to that is we did not take shortcuts in vaccine development. And the fact that it's still considered experimental is a function of the care that the FDA takes with every vaccine and with every drug that gets presented to them. The reason that we had these vaccines so quickly is not because we took shortcuts, not because we didn't do the appropriate steps in the developmental process, but because we did them all simultaneously instead of doing them consecutively. And that and by that, I mean, not the developmental procedures, but the manufacturing procedures that need to be in place to make them available. So in a normal vaccine development process, you'd be going through a phase 1 evaluation. We did this in a rapid way because we threw a massive amount of money into the preclinical development and into the enrollment of patients in vaccine trials. And many of my colleagues at UCSD will tell you how quickly we deployed vaccine trials across the country and across the world. And that was because massive amounts of dollars were made available to us by the companies who were developing them and by the federal government in order to give us the kinds of tools that we needed to rapidly enroll patients in those clinical trials. So the logistical setup was accelerated, not the development process itself. So we went through every single stage that we normally would do for vaccine development: animal models, animal testing, phase 1 studies, safety and dose ranging studies, and then large phase 3 trials. But we did each of those by enrolling in a rapid manner. And while we were doing that, rather than, like most vaccines, waiting until they're approved to put together all of the tools to manufacture and in vast amounts to get the manufacturing and the deployment of the vaccines, we did all of those things while we were doing the clinical trials, with the understanding that we may be spending money on a manufacturing process that we would never use, but if we were lucky and these were effective vaccines, that we would be ready to go when we had the data from those trials. So there were no shortcuts taken in the development of these vaccines. And as Dr. Brown said, they have been in development for more than 20 years. The construct with mRNAs has been used in the Ebola virus vaccine development, in development of vaccines that began with the first SARS outbreaks and MERS outbreaks a decade ago. So these are not vaccines that were developed quickly without doing all of the normal safety and efficacy and animal model studies that we would normally do. So that's how I respond to people about experimental.
Yeah.
So I have the same question that all of you do. Why hasn't the FDA approved these yet? I'm a skeptical physician, and so many of you in the audience, I imagine, are as well. And I don't know why the FDA hasn't approved them. They have all of the data they need. We've given, just in clinical trials in the United States, we've vaccinated more than 200,000 people in big vaccine trials. That's more data than we have for any other vaccine in the history of development. So I think part of their delay in approving these vaccines is maybe politically motivated. And I don't mean that by they're being manipulated by politicians. I mean that because they're concerned about the amount of attention and focus and scrutiny that they're under, and concerned about making mistakes and not getting the message right.
Mhm.
But I think there now a substantial movement to get this done. So hopefully it will be before too much longer.
And if you saw that survey, the number one message to the wait and see group is if it becomes FDA approved, would you get it? So when it becomes FDA approved, which is hopefully any day now, messaging that is going to be very helpful. And one thing that before we leave, the role of the employer, especially for our younger age group, is really critical. Employers are doing some wonderful things. It's very effective if the employer encourages it. And things like everybody, I know one organization that if they got to 70% vaccination amongst all employees, they got an extra 4th of July weekend. They got the Friday off instead of in addition to the Monday of 4th of July this year. An additional $20 or $30 into the cafeteria fund. So celebrating, and again, that group think, turn it into a positive. And then other people like, go do it. I want that Friday off. Go get your vaccine. Let's get up to 70%. We can be a little bit more creative and turn to our employers. And if they're self-employed, they really want their employees also from a profitable standpoint, because they're the cost of somebody getting sick and just in dying, losing their employees is very real for them. So they're highly motivated on many levels.
Well, that's a great answer. So I think I'll turn to our IAS-USA colleagues. I think we're nearing the end of our time here. I might answer one more question just because I like to give my personal opinion about this. I'm not a politician, but I do believe that we're at a stage in the US that we should be making vaccination mandatory, certainly for healthcare workers. I think we see the most vulnerable people in our medical practices and in our hospitals, much more so even than the rest of the world. And I think we have a responsibility to be vaccinated and to protect our patients and the people that we come into contact with. But there was a question from the audience about what are the legal repercussions or consequences of mandatory vaccination. And I think what you're starting to hear from the news media and making it abundantly obvious, the Supreme Court weighed in on mandatory vaccination during the smallpox crisis in the United States and said that it was within the rights of the federal government and employers to make vaccination mandatory to protect the health of the country and the public health interest. So that's already been adjudicated for people who brought lawsuits for mandatory vaccination in colleges and universities and in hospitals, and has been adjudicated in federal court, hasn't been taken all the way up to the Supreme Court as of yet. But I think most of the information we're getting now is that it is legal and there are unlikely to be major legal repercussions. in a public health emergency when we're doing something for the public good. So that's the answer I give to that one. So I think we'll stop here. I know we may not have gotten to all of your questions. I think we did a pretty good job for the ones that came in during the program and during the pre-program question and answers. So I think we need to close for today, and I'm going to turn it over to our IAS-USA colleagues to tell us how to do the evaluations and how they can how our registrants can receive the slides or a copy or view the webinar. So,
and thank you for attending.
And thank you very much
for all your work.
For Dr. Brown's wonderful work in this area. It goes well beyond COVID, and for all of your attention.
Thank you, Dr. Brown and Benson. Evaluations and information on how to claim continuing education credits will be emailed by 5 p.m. tomorrow, and this will enable us to review all of those that have attended today's live podcast. As a reminder, the on-demand activity as well as slides will be available within the next 24 hours.
Thank you. And you can check the website, the IAS-USA website, and we do have posted on the website frequently asked questions. So hopefully if some of the ones from the audience or this discussion or additional ones didn't get answered during the program, we can post some of those on the FAQ section of the website. This is, as you're seeing on your screen, we have a number of other webinars available for sign up. So again, thank you all for your attention, and we look forward to seeing you again. So.
Thank you again, Dr. Brown and Benson, and to our audience for your participation. This concludes today's webinar.